Hi everyone, back for a Sunday morning bash. And the topic for today is endometriosis and IUI and IVF, that is MAR. Before I move ahead, a small backgrounder of ICEAT. At ICEAT, we always believe in giving things in a very simplified way. I don't like giving information which has been mixer grinded. We make processed food, we never give. We give you something very simple, which is very easy for you to understand, comprehend, looks fresh. Same thing we will rediscover along with you and then present it to you. So let's uncomplicate. This is my favorite picture. I don't know why I show it again and again. I try to change a lot of pictures, but this is my favorite picture. Let's uncomplicate thing. Let it go. When you come for this sort of classes, let it go. Whatever you have in your mind, let it go. Let's start fresh. That will be my motto. Learning has become very easy with the multimedia. Very easy to get information from many sources, but difficult to actually comprehend. We get so much of information that we don't know what we should do. So these are a few courses which we offer to people. We have courses on IVF, we have courses on IUI, we have courses on embryology. We have a virtual university where we have more than I think 50 hours of data available for you to go and view. We call it a virtual university. We have got some YouTube channels where you can go and learn how to manage the cases. Our YouTube channels of embryology and IVF are not meant to sell our name, to sell our channel. We are not there to have large number of subscribers. No, definitely no. They are for you so that you should know what patients are going to ask you. क्या पूछेंगे आपसे और क्या जवाब देना है? They've been made with that content in the mind. We have got COVID scholarships where we give people completely free scholarships, completely free. So in case you know somebody who is actually poor, who cannot afford, he can always come and join us, and we'll be offering him completely paid courses. We have a few seats in every category. Okay, fine. Then we have got something called Resonance Series. It's for you guys and girls. You run it. Resonance Series is one thing which you are running it. We invite any one of you by your choice. You can come and make a small bulletin of 3 to 4 pages. This is our gift to you, where we do complete mapping, complete designing, formatting, and then we share with our own gang of people. So we had one on understanding oocytes, on IUI, hyperprolactinemia, benchtop incubators, hysteroscopy, genetics, so multiple topics we have. Curtain raisers have been very dear to our heart. We started curtain raisers somewhere last year. I don't even remember now, maybe around 1.5 years back. And we picked up topics which are very different, very, very different. And we spend around 1 hour with you all in the morning. Normally, initially it was 11 a.m., but now we have shifted it to 8:30 a.m. So microscopes, air quality, OPU needles, ET catheters, embryo transfers, IUI protocols, ultrasounds, gonadotropins, luteal phase defect, azoospermia, then another one on IUI tips and tricks on great demand, adjuvants, HSG, hormonal evaluation. Then we had one on ovarian reserve assessment. This one we are having on endometriosis, and next month, this month end, we are having one on sexual dysfunction in the men. They're all by the demand. Whatever you demand, we normally start preparing for that. So in case you have something in your mind, do let us know. Coming 45 minutes, we're going to go back to the school days and learn things in very, very simple way. As I say, let's start building up alphabets. So let's not go to huge data, huge references. That study says that study says that, there's a conflict, there is an RCT, meta-analysis. Let it go. Please let it go. Let's see what is endometriosis and how does it affect fertility part. This is what I'm going to talk to you about. Endometriosis is synonymous with endometriomas because this is what we actually treat. Otherwise, people who come to us until they have very grave pain, we don't go and do laparoscopies and start classifying our endometriosis. We don't do that in IVF anymore. So poor thing, a healthy young woman comes, She may be symptomatic, may not be symptomatic, and half the time they are asymptomatic. Majority are asymptomatic. And when they come to us, their uterus is bound. They're bound by certain toxins. They're bound by the menstrual blood. And the uterus is not able to work properly. Uterus may be sad. It is unable to perform its duties. And then what we start is we start putting some patches here and there. So what you will do is that you would have learned someone giving OC pills. Somebody gives Danazol. Someone gives Dynogest. You start pumping medicines here and there, and we start doing band-aid things which we want to do and trying to push endometriosis out. So endometriosis is not a disease which you can actually fight. It has to be very gradually friended. Then we have to make it move away. And the best enemy or the friend of endometriosis is pregnancy. So make the woman pregnant. The moment the woman is becoming pregnant, I'm sure that the outcome becomes better. So let's decide today that we won't put band-aids for the people who come to us for infertility. For pain, yes, we've got multiple options. You can give them antagonist, agonist, you can give them whatever you want to give them, OC pill, letrozole, you can give them anastrozole, give them anything. You can give them uripristol. But for us, for infertility, there is no band-aid phenomena. We have to have very, very certain methods of doing it. So how I decided I'll take this topic forward is that I thought that let's look at few common queries that you people ask. I thought about it. So I could focus on 11 questions which you people ask. So these 11 FAQs I'm going to talk to you in detail. And then these 11 questions have got very specific answers. These I have taken down from our clinical experience and few papers available in the market. And just to look at endometriosis, there is nothing new has come in endometriosis in the past 4 to 5 years. Probably, I don't know, we lost focus on endometriosis. I thought so. From the Australian journals to ASHRAE to NICE to ASRM, I think everybody's quiet over endometriosis. No one is talking about it. I felt, is there something new? And I was very happy to find that ASHRAE is coming up with the guidelines and the draft is already, they have floated. So ASHRAE is coming up with a huge, nearly 100-page document. I think so. That is going to turn out to be a big bulletin on endometriosis. Draft is already out. And we'll be talking about that bulletin today again. So yes, we have multiple options, multiple papers. Every paper we'll discuss, but finally we will all sit down and see what is right for us and how we should move ahead. A bit about pathogenesis and a bit about prevalence is what I'm going to talk to you about. Somehow I won't talk to you about, I'll avoid talking to you about medical management, because medical management is primarily for pain. Anything about MAR, yes, we'll talk. But medical management for pain, I will avoid. And classifications, I will avoid. Classification is a huge subject in itself. I'll give you a small glimpse, sure to you. And that's it. Otherwise, I'll go to the proper management per se. Okay, endometriosis is an enigma. I think in case I raise a query amongst all of you, I have around 162 people present here. I think all of us will differ in the management of endometriosis because we have learned from different teachers, different ideas we have. So endometriosis is a very, very conflicting subject. So let's make it very simple today. What I will do today is to review a few papers and give you the final answer, which is my take. And the difficulty lies in the learning. It's not in the new ideas, but in escaping from old ones. So it's very difficult to leave the old ideas, what we have learned till now. Let's make an attempt. Let it go. Let it go. Let's look at the thing like the small baby, fresh, very fresh. Let's some new ideas germinate today. Let's think like a child and not as somebody as antique as me at 55 who doesn't want to change anymore. Let's be a child again for 45 minutes and let's find out what we can do when we look at endometriosis. But for some things, I still go back to Jeffcott or Shaw, basic books which we read. I think I read those books around 20 years back, Prof. Let's have a bird's eye view. How does a bird, when you look at endometriosis from top, how does it look like? So endometriosis is an issue. It's a big issue. This we know. Endometriosis affects various parts of the body. This we again know. It can affect the uterus, tubes, fallopian tubes. It can affect endometrium itself by causing adenomyosis. It can affect ovaries. There is no part of the body which can escape endometriosis. It can just, metastasize like a cancer. We don't get, in our population, we don't get very bad endometriosis cases because we probably catch them young. And not many people come to us with pain. They come to us with infertility. This is what I am finding in our population. So when they used to come to us with pain, it's very easy to treat them. We have a high index of suspicion when they have pain. We know that they got an issue, put a scope, fulgurate, burn, whatever we used to do. But nowadays we get young girls and boys who come to us in the OPD, and large number of girls have got endometriosis, and they may be asymptomatic completely. So there is not much of option for us to put a scope in all the patients. Though I always differ with a lot of laparoscopic surgeons, but the guidelines are very clear. We don't do scopy to diagnose endometriosis anymore. So it's an endometrial-like tissue outside the uterus, which induces chronic inflammatory reaction. Wherever the endometriosis is going to get implanted, it causes chemical reaction. Let's remember that. So that's the way endometriosis works. Starts at puberty, peaks at 40, and then decline at menopause. And it's in this whole journey, how do we help a woman? We can make, in case we make her pregnant by MAR or by giving her some sort of counseling and treatment, I think the growth of endometriosis is halted. The biggest friend of endometriosis is estrogen, and the biggest enemy is again estrogen. The more estrogen she will have, endometriosis will get suppressed. And there's a saying in the north that lohe ko loha kaata hai. So endometriosis can be killed by making the woman pregnant. So give her 2 pregnancies and probably it'll end to quite an extent. So it's a negatively affects quality of life. Now this part doesn't affect us much here because we are not dealing with the women who have got primarily who come to us with pain. Not many come to us with the pain. So I'll be talking about infertility part more. And then there's a balance we have to draw because in case we start treating endometriosis, she will lose her fertility. So understand that whatever we have been doing till now to treat endometriosis is going to delay her fertility. So anything which can delay her fertility is not good for us. And anything which will delay her fertility, but the moment you stop the treatment, it's going to bounce back. So something like keeping a snake in a small basket and thinking that, okay, we have captured the snake. But my dear friends, gentlemen, ladies, the moment we'll open the basket, snake is going to come out. That's what endometriosis is. It's going to bounce back with vengeance. And the only thing which it cannot actually fight is pregnancy. So let's kill it with pregnancy. Kill it by giving women fertility. Okay, so this is what we have in front of us. 10% of women, in case you look at the common population, they have endometriosis. 10%. And around 50% of all women who have got endometriosis may be infertile. Huge number. It's a huge number, huge clientele. And then there are a lot of theories, a lot of things, staging, treatment, age-wise distribution, common symptoms. 1 in 10 women have got endometriosis. I say that 8 out of 10 men are having sexual dysfunction, which I'm going to cover in the next class. 1 in 10 men have got azoospermia to come to our OPDs. Endometriosis is that common. Endometriosis, 1 in 10 women have got a problem. How to manage them? Because they don't come with it. We really can't see it. Stage 1 and 2 may not be seen at all because it is very minimal to mild. It is not seen. How do we treat it? So it's a challenge. And these are few, just want to give you again and again few pictures before I go to the talk per se. Very common, a large number of women in India and abroad, young women have got endometriosis. High estrogen, genetics, risk of retrograde menstruation. There are few things which we have been learning. Every webinar talks about this. And in our classes, we don't talk about webinars and common things which you already know. So retrograde menstruation, coelomic metaplasia, metastasis, stem cells for any PG who's with us. Just some information, I'm giving it to you. The most commonest cause here is the retrograde menstruation, where the blood flow doesn't go outside, but it comes inside and gets implanted over the uterine surface externally, ovaries. It may go through the endometrium and cause adenomyosis. So that's the most beautiful part of endometriosis. It can go to any part of the body, and it can lead to apoptosis, suppression, stress, genetic, hormones, immune dysfunction. And this is where the problem starts. Because the moment you look at it, we start giving them large number of medications, large number of tablets are given to them. Somebody will give OC pill, somebody will give them letrozole, somebody will start pumping in GnRH analog, somebody will start giving antagonists. So whatever comes in our hand, we start giving to that patient. Some give ecosprin, some give pentoxifylline. जो भी मिलता है, we give it to the patient. So basically, we want to suppress her pain, inflammation, but some want to change immune dysfunction. But remember, these things, they don't work. These things, they don't work when we talk about infertility. In infertility, these things are not very, very important and should be avoided. Good. Moving ahead, how can I, forget some nice pictures and gifs which I've taken from the internet. So when we have retrograde menstruation, as you find here, we always find that the blood is gonna come out, and when normally blood comes out, but in this case, the blood is not gonna come out from the vagina, it's gonna go back. This is what it happens here. And then menstrual cell debris is gonna stick on the body surfaces internally, externally, on the body organs, and they start surviving. They start surviving, and this is due to some predilection they have, that they are not suppressed, but they start surviving. And then they lead to adhesions in the body, they lead to proliferation, angiogenesis, and this is all about endometriosis. Now, we want to stop them here, we want to stop them here, we want to stop them at this point of time. So we use multiple drugs, but they don't work. Gentlemen, ladies, these things, they don't work. In case you start doing these things, probably the fertility will be delayed, but the outcome won't be good. One slide, I just want you to know that these things happen in the body. So we try to catch them at various stages of management, but this is okay for pain and discomfort, but not for fertility management, is what I like to tell you. So good, we are here, and I'm gonna hit that topic. I was waiting for things to build up. Now we are 201 people who have joined today by now. So let's now build up the topic gradually. Whenever endometriosis starts building up, we'll have endometrial cells in the menstrual fluid. We'll have them causing adhesions, invasions, cell growth, fibrosis, prostaglandins, angiogenesis, and apoptosis. So we start giving them, we start managing them at various places. Okay, but it doesn't work out, is what I want to tell you again and again. And now look at what happens when somebody has got an endometriosis. There can be dyspareunia. This is important for us. This is very important for us now. We have to know that adenomyosis can cause problems to us. Fine. Then we have got things like LIF, beta-3 integrin. They are good for us actually, but the values they start going down. As a result, it'll damage the sperms and the embryo implantation. This is all what happens in the endometriosis. So without correcting these things, doing any MAR, that is medically assisted reproduction, is not the right way. So we should not be doing MAR without correcting these things. One more thing I'm finding, that all these young women who come to us, they have got high values of LH. They are LH hypersecretors. So we have to suppress LH and then you carry out. I had a couple of patients who came to me with E2, basic E2 LH on day 2, day 3, very, very high. So I think suppressing them and bringing them actually hyper-responsive is the right way to take them further. Diagnosis of endometriosis, again, there are multiple diagnoses, but our patients are normally quiet. Our women who come to us, they're very quiet women who come to us. They don't have pain. Some may have, they pop in some tablets, but majority of them, they come to us in a very simpler way. that they are unable to conceive, and endometriosis is an incidental finding. That's what happens at a good IVF unit, because as a gynecologist, you may get people with heavy periods and painful periods, pain with bowel emptying, multiple things. But when you reach an IVF unit, by the time they reach an IVF unit, majority are cases who are having infertility and they're quite settled, and endometriosis becomes an incidental finding. Okay, now the diagnosis can be multiple ways, but simply just remember that the right way of diagnosis is, for us in an IVF setup, is normally an ultrasound. This is what we do and find out, and we actually cannot discover many times mild and minimal endometriosis. We are able to discover endometriomas, and by that time they have become stage 3 to 4. And our debate starts whether what to do with 3 and 4, we should operate upon them. But for a general gynec, a large number of you who are starting your own practice now, you'll get a young woman who will come with acute pain, all the features of dysmenorrhea, dyspareunia. So I think that's the time, in case you look at the age, you look at their presentation, their acceptance for MAR, that's the medically assisted reproduction, you can do a laparoscopy and treat. Fine. Okay. So ultrasound is a cornerstone. MRI, I don't know. I've never done an MRI. Laparoscopy, yes, is a wonderful tool, but again, with a lot of pinch of salt. Moving ahead, we find that endometriosis is a chronic disease, first of all. It needs a lifelong management. Goal of maximizing the use of medical treatment and avoiding repeated surgical procedures. And here, my choice, my call would be to take it very gently. Don't just start operating. This is one thing which you should not do. I have a debate with a lot of people. I say don't operate unnecessarily. But there's a big debate between the laparoscopic surgeons and debate between us. But I think the debate, the verdict is already out, and that says don't operate. Endometriosis. Now, coming to the topic back, how do we manage our patients? Endometriomas are known to us. We know how they look for us. So GnRH is a good friend, first of all. Now, GnRH is a good friend for us, and we use GnRH at multiple places. So all of you who have attended our curtain results before, you will realize that GnRH works beautifully for luteal phase support, ovulation trigger, fertility preservation, fibroids, even for carrying out ovarian stimulation. So we have to, when we talk about endometriosis, we should be making friends with GnRH analogs. And this is important thing for you to know. It's a lovely tool for causing suppression, but again, now coming into debate, as you'll go towards ASHRAE, as you go towards ASHRAE 2021 endometriosis guidelines, they will put agonist and antagonist back to back. So let's see. So these are a few methods where we find that we use GnRH agonists, and GnRH agonists are perfect for endometriosis and adenomyosis. They work pretty well. And there is no role of any other drugs in IVF per se. Using Dynogest, no. Ocipil, no. Letroz, no. So whatever medical management, Danazol, we were using very frequently, no. All these things have gone now. So only friend we have is GnRH agonist. Now mind you, I'm talking to you as an ART clinician, but not as a gynec who see women coming to them with pain. Here we're talking about infertility problems. So that's it. We have to be very guarded about what we use. So endometriosis treatment goals: relieve pain. Yes, relieve pain, most important. What will fertility do in case she's crying with pain? Relieve pain. Slow the growth of endometriotic tissue. Very difficult to do. It will always come back. Always come back. Only way to suppress it is by giving her pregnancy. Improve fertility and prevent disease reoccurrence. And this is what I'm going to talk to you today. Today's topic is improving fertility. Okay, good. So now moving ahead, there are now 11 burning issues of clinical relevance. Review the literature and find an answer. Now here, what we'll do is, we'll go to 4 or 5 articles which I could find. Some are old, some are new, but they are the last ones which I could find on the internet. So we have a journal from, we have a Journal of Obs and Gynae, Canada. It's a 2010 edition of July. Then ASRM 2012, Endometriosis and Infertility. We have got NICE guidelines of 17. We have got fertility assessment guidelines. We have 13, again from NICE. They have spoken about endometriosis. ASHRAE 13, and ASHRAE, gentlemen, ladies, is going to come out with full big booklet. I'm going to send to you now. As promised, within half an hour, I'm going to send you 4 papers. 4 papers will be reaching your chat box. Just go through them. So ASHRAE guidelines are coming 2021. Huge one. So please read it once. They're in a draft form presently. Stages of endometriosis. There are, I'm not going to talk about endometriosis staging at all, but you should know that there's something called minimal, mild, moderate, severe. And now, how do we make out stage 1 or stage 2? Actually, we cannot. We really cannot on ultrasound. Ultrasound, getting them is nearly impossible. Laparoscopy, yes. This means that we start doing laparoscopy for all to diagnose them, because once you do laparoscopy, you have a better clinical pregnancy rate. But again, looking at this, laparoscopy is not to be done for all the cases. So this is a big debate we are having. How do we diagnose endometriosis? So for us, we normally say that we go by the clinical diagnosis and we look at the ultrasound findings. And when we reach stage 3 and 4, we can diagnose by ultrasound very easily. Before that, some people can, but it's very difficult. In my career of 20 years, more than lakhs of ultrasound, you can't say that patient has got minimal or to mild endometriosis with a lot of confidence. So this is revised ASRM guidelines. Again, you can see there is something called stage 1, stage 2, stage 3, stage 4. I'm not going to talk about it. I'm not going to talk about it, but you should know that this sab hota hai, and we are catching people normally here. Superficial lesions and these things, very difficult to find out, very difficult to catch on ultrasound. And laparoscopy, we don't advise for all. So great, good. EFI. EFI is a very good method. EFI works pretty well. And the higher the score of EFI, as you can see here, clinical pregnancy rate is higher in patients with EFI more than 6. This is a chart. I'm not going to talk about it. I'll send you articles, you can read them. I'll move ahead to burning issue number 1. So I'll take a small halt here. And say hello to all my friends which are present. I can see so many friends who have joined back now. Any queries from you till now? And Dr. Vanita, thank you so much for the slides on classification. They were a great help. Anyone having any queries till here, this point of time? Now I'm going to go to 11 questions, burning issues. I've covered some basics. Now it'll be quick round.
You told, sir, EFI?
Yes, EFI is a fertility index, and that's a way to grade endometriosis. And I think it's a very nice method when you do laparoscopy to grade endometriosis. Higher the score, better the chance of the woman getting pregnant. Fine. So you can read about EFI scoring. So you have to read about revised ASRM or ASRM. Read about, and I'm going to give it, I'll be giving it to you. And also read about revised ASRM and read about EFS grading when you talk about endometriosis. It's theoretical, but you must read them well. I'm not going to cover here today because it's a huge subject. I thought I'll cover it some other day. It will take me around 1.5 hours. So barring that, anything else you like to ask? Any doubts about endometriosis which you face in the clinical dilemma? We'll do one thing. Before I start telling you my 11 queries, My, could you please switch off your mics, all of you? So, before Sunday, could you find out who's making so much of noise and click?
Yes, sir, yes, sir, I'm doing it.
Please do it quickly. Yeah, so what we'll do is, I have given you my opinion till now. Now I'm gonna go on 1, 2, 3, 4, 1 to 11.
Hello.
I've covered everything.
Yes, sir.
So now, am I audible to you people? Am I audible?
Yes, sir. Yes.
Yes, sir.
Now I like to ask you your questions.
One question I'll ask you, sir.
11. I won't answer. I'll see whether they fit into my thinking or not. See, then I'll go to my 11 questions. So what I'll do is I'll start writing down your queries on a piece of paper, and let's see how many I missed. You know, that'll be my test. So what you can do is start telling me about the questions now.
One question.
Yes, please ask. I'll write.
Yeah. You told that there is no letrozole, nothing. Go for the GnRH agonist. So
no, I didn't say that. I did not say that. I said they are not effective.
Okay. Yeah.
The only thing you have is GnRH agonist in our hand. I never said you don't go for that. I mean, only thing effective is GnRH agonist, because this is for fertility management.
But when they are trying normal pregnancy, still will give GnRH agonist only, sir. Okay,
so you want to know about GnRH agonist. Okay, fine. Question taken.
Yes, sir. Thank you.
First question. Let's see whether I cover it or not. Medical management ka part. Next, anybody else? I want you to throw questions at me now.
Question, sir.
Priya,
23-year-old, married since 6 months, and she has got small endometriomas of size less than 2 centimeter in both ovaries. She is not willing for IVF, sir. And what is the management, sir?
Fine. Priya, no? In case I'm not wrong. Priya, want to know about Hemlata. Sorry, sometimes I mix the names. I apologize for that. Sorry. So endometrioma size and MAR. Fine. Point taken. Second question. Third question. Anyone? Shoot a question.
We decide
that endometriosis.
What, ma'am? What, Priya?
So is there any role of AMH while managing endometriosis?
Role of AMH. Okay, done. Point number 3. Noted. 4.
So where will you categorize frozen pelvis as? 3 or 4?
Where will you tell me?
Stage 4?
Yeah. Starting from stage 3 to stage 4, I'll say stage 4 to be very, very confident. I'll go back to the classification. Point noted. Next question.
The role of Indian classification.
Indian, I won't know. I won't talk about Indian classification. This topic I won't touch because this is a Pandora's box. I'm sorry. Next class probably we will take it, not today.
Okay.
Classification I'm not touching because it's going to take the whole lecture in a very different direction. Then it won't be able to give you the take-home messages. So I'll pass.
So role of hormonal replacement therapy. Hello.
HRT, add-back therapy.
Yes, sir. Before ART and before and after surgery.
Point taken. Added. Noted. Yes. Next. Anybody else? Quickly.
Correlation of size of endometrioma and its management.
Written.
Unmarried patients with chocolate cyst of 5 centimeter in both ovaries. What is to be done?
Yeah, unmarried woman. I'll park it here in other corner. Unmarried woman. I was not dealing. Okay, fine. I'll take it. Next.
Sir, endometriosis and its effect on the endometrial lining.
Endometrial lining. Okay, this is very important. This is a very relevant question. In fact, this is one thing I'm afraid of. I'm actually scared of endometriosis. I'm scared of this question. And my whole management is afraid of, when we manage cases, I'm afraid of 2 things. One is premature LH search, one, and endometrial lining in endometriosis. Fantastic. Hi, Niti, how are you?
Sir, HSG and endometriosis.
Very, very debatable question. Very debatable. I'll make you answer this question, Niti. You're gonna take this question.
ART in adenomyosis, sir.
Okay. Adenomyosis. Wonderful questions coming now.
Sir, treatment of endometriosis in unmarried girls.
Unmarried girl, I've already parked it in one side. Okay, done. Anything else?
Aspiration of endometrioma.
Aspiration. Good.
The role of
You said that we should not operate endometrioma as far as possible, but the large metriomas have to be operated.
Yeah, size of endometrioma, I'll come to this. Very quickly. I'm going to come to
Any
this.
role of surgery?
Adenomyosis, sir, obscured endomyometrial junction, how it affects the fertility?
Okay, I've already covered this some time back, but I'm going to talk adenomyosis. Done? Okay, what else?
Any role of surgery in adenomyosis?
Role of surgery?
In adenomyosis.
Okay, done. What
Who
else?
said quality and deceptive?
Who said quality? Done.
Done in a patient for bilateral endometrioma, post laparoscopy, the patient again develops endometrioma.
She will develop. Surgery not done properly. It will develop. Tabhi we don't operate endometriomas. I'll come to this. Point taken. Point parked. I think we have got enough questions, and I failed at one point of time. I didn't consider unmarried women, because unmarried women was not part of my bucket actually. So I didn't. Otherwise, all questions have been covered. And yes, adenomyosis I missed in such. Somebody is making nice drawing on my slide.
Hello, sir. Endometriosis and ovarian trigger. Should we be HCG or a GnRH trigger?
Okay.
So sometimes in IUI cases it doesn't rupture.
Okay. Trigger. Good.
Sir, when pain and fertility both are the issues.
Yes. Good. Pain and
Preparation for FET in case of endometriosis.
yes, very important. Who was that? Who put this question?
Lisa Chaudhary.
It had to come from you, Lisa madam. It had to come from you. That is one killing point, one killing question. Thank you so much. It's a killing question. Assalamu alaikum, ma'am.
Walaikum assalam.
So somebody is writing on my slides. In case possible, can you erase it? Can someone find out who's the painter here? Who's the surgeon on my slides? In case you can do it, it'll be good, because these things are being recorded for. Sanjay, can you find out who's writing on my screen?
Yes, sir. Yes, sir.
Please don't do it, because these are for circulation later. Okay, great. तो एक एक सवाल पकड़ेंगे अभी हम और जवाब देंगे. So पहला सवाल which I'm going to take for you is adenomyosis. See, the only thing which I'm afraid in whole of endometriosis is adenomyosis. Adenomyosis is nothing, but when Sandhya, could you spot who's writing on the screen, and please cut it off.
Sir, I'm checking, but I don't know.
Can someone remove this stains, because it's a humble request. Don't write on the screen.
Sir, you can go to stop annotation.
I don't have so much of time. No, I don't have time. I'll do that, but I don't have time. I'll do this. I don't have time.
Somebody called Shomili, I think.
Stop annotation.
Somebody called Shomili. The moment there is a pen scratch, the name Shomili appears.
I don't know how to do it now.
Yes, yes, sir.
You can remove her in case possible. Just remove her.
Okay, sir.
मैं निकाल रहा हूँ, मैं erase कर रहा हूँ. You can remove her from the group in case she doesn't. I'm doing it for her now. This is not the right thing, no? Okay, I'm erasing it. I was avoiding it till Dr. Gupta told me to do this. Okay, great. I've done my bit. Thank you, Dr. Gupta. Adenomyosis is nothing but presence of endometriosis in endometrium. Adenomyosis, what it does is, it's gonna grow in the myometrium and make channels. See, it has to go through the endometrium only. So it will break the endometrium, make microchannels, and go through the microchannels to the myometrium. This is what happens here. And let's look at it, how it goes inside. Okay, this is the lining. This lining will be a little breaching here. Breaching occurs, the menstrual fluid will go and form an adenomyoma here. So these adenomyomas, when they're going up, they're always connected with the endometrium. They're always having some connection with the endometrium, and these connections are the one which will always keep bringing out the toxins throughout the menstrual cycle in the endometrial cavity. So now look at this. The whole cycle, this will keep leaking and coming this way. It'll keep leaking. And endometrium, when it keep getting infected with the interleukin cytokines, it becomes unreceptive. I always find these women have got lower implantation rate. And this is a problem with the adenomyosis. And adenomyosis, to diagnose adenomyosis is by 2D. So can any of my family members, you're my family, I sit family members, tell me which is the best method to diagnose an adenomyosis?
3D ultrasound.
3D ultrasound. Good. 3D ultrasound. Sandhya, chocolate. 3D ultrasound is the right method. Nothing else is required. Don't go for big things. 3D is the right method to do it. So 3D kar liya, you find on 3D, you find there is an adenomyosis, but you can never know whether they are breaching inside the endometrium. So you tell the sonologist, we always tell the sonologist to look at the breach of the endometrial myometrial junction. So when I write for adenomyosis, I see it on 2D. I see it on 2D, and then I look at breach. I write, tell me, is there any breach in endometrial myometrial junction? This is what I do. Just my answer. In case breaching is quite evident, there is avulsing of the endometrial myometrial zone, this woman will have lesser implantation rate. And many of them, they need surrogacy. There is some role of surgery for adenomyosis, but I'm not very sure. I'm actually not very sure how people do it. Yes, we get pregnancies, but that is one surgery which you should not all attempt. Mat karna. Don't do it until you are confident. Otherwise, you're going to cut open the whole endometrium. It's going to cause more harm. Dr. Alka Kriplani does a lot of work on this, in case you know her. The Alka from Delhi. She's fantastic endoscopic. She specializes in adenomyosis. So in case of any patient of adenomyosis, send to her. She's the best, I know. Okay. So there is no role of surgery in adenomyosis as far as possible in case there is no breaching. I think we can give her suppress, and then with GnRH analogs you can suppress, or you can also use LNJ. You can use Marina. Give her Marina for 3 months and then go for IVF. This is what I have to do in all adenomyosis cases. Before FET, for 2-3 months put in Marina. This will suppress adenomyosis. So burning issue number 1. Effect of endometriosis on IVF outcome. Does endometriosis reduce the chance of IVF success rate? It's a very commonly it comes to our mind. How does it happen and does it happen? So when you look at it, you'll find that the ART results depend upon the severity of the disease. We know that as we move towards minimal to moderate, then severe, very severe, frozen, the disease severity is rising. And when the disease severity is rising, what happens? The tubes are getting choked. Tubes are affected from outside here, not from inside. Tubes may be functional, but they are getting compressed from outside. We also know that there can be an anatomical distortion, number 2. Number 3 is adenomyosis. Number 4, the chemical toxins coming from everywhere. 4th is fall in AMH when the ovaries are affected. Ovarian cortex can also get damaged. But remember that when the live birth rate is not affected, as per the data we have, the quality of the oocytes is not very much affected in case you do the pickups properly. Here comes the role of a good embryologist. Keep washing the eggs, keep washing the OCG complex multiple times, and because you remove all the blood and hemosiderin, the fertilization rate is not much impaired. I've been doing embryology from 20 years now. It doesn't, and I agree to these guidelines which we see all over the world. But we have to know how to handle endometriosis. What I do is that the moment I get an OCG complex out, I wash it very quickly and then remove the oocyte cumulus complex. Just cut it, cut it with a blade. So get an OCG complex with minimal tissue on it, minimal cumulus complex, and then do ICSI immediately. So I think we get good outcome, but that's a trick people have to follow. So any embryologist present here but probably will agree that this is one way we all actually are following. So problem here is that there may be less number of oocytes, number 1. Poor quality of oocytes may be there in case we don't clean them properly, but I have not found that they are of poor quality. We have never found that they have less number of M2 oocytes. That doesn't happen. By the way, how many of my friends have read Maribor consensus? It is for my family, ICIT family. How many of you have read? How many of you have not read? If you have not read, all your chocolates will be cancelled in the future. No one has read.
Sir, we'll read today.
You'll read it. Any E8 batch present here? E8 C2? E8 C2. Anybody from E8 C2 here? Or E8 C3? पढ़ना है इसको, ठीक है? Very nice. I've already sent on your groups. Please read it. This will answer my question here. So, when the embryogenesis is occurring, there can be a problem, and this occurs due to toxins present in the endometrial cavity, which come from adenomyosis. Adenomyosis is pretty common. So this is what I like you to tell. So it doesn't affect the quality, but embryogenesis and other things are definitely affected. But here I think it doesn't actually lead to low birth rate in case we do the things properly. So mild is comparable results, severe reduced implantation. So ladies and gentlemen, and few gentlemen and majority of your ladies here, just remember that there is reduced implantation. It is not the quality of embryos. It is the reduced implantation. And live birth rate was not statistically significant. Understood? Anyone having any doubt here? Any of ICT and survey any doubt? In the future, I won't take any question on this topic at all. I'll refer you to curtain reviews. I've ended. You keep asking me, does it affect the outcome? So endometriosis doesn't affect the outcome much. My experience is that AMH can be low, ovary may be adherent, less suicides are retrieved. It's a different ballgame altogether. It's a different thing, but it doesn't affect the outcome directly. Okay, clear? So endometriosis doesn't affect outcome in IVF in terms of egg quality or embryo quality, but other things are always there. Implantation.